Next talk is by Dr. Satish. He is talking on upshoots in Duanes retraction syndrome. Dr. Satish Thomas is the head of the pediatric ophthalmology department in Believers Church Medical College, Tiruvalla. Over to you, Dr. Satish.
Thank you, Dr. Laila, for giving me this opportunity. My topic is a simple one, just on the overshoots in Duane retraction syndrome. As you know, Duane's retraction syndrome is a cranial dysgenesis, disinnervation disorder, where there is congenital agenesis of the lateral rectus nucleus, and the lateral rectus is supplied by a branch of the medial rectus, and therefore this causes co-contraction on adduction, and there's limited abduction in the type 1. And so the lid fissure narrowing and globe retraction are main features. We have this publication in the Middle Eastern African Journal where in dilemmas where you don't know whether you're dealing with a lateral rectus palsy or a Duane's retraction syndrome, the MRI Fiesta imaging, the fast imaging steady state acquisition, that helps us in solving this dilemma. In this picture, how do I go back? Okay, on the right-hand side, you can actually see the abducens nerve here traversing the prepontine cistern to enter the Dorilo canal, and it is absent on the other side. Thank you. This one here, and it's absent on this side. So the indications for surgery in Duane's retraction syndrome, the main two indications are the face turn and the disfiguring upshoots and downshoots. The retraction, the globe retraction and the limitation of movement can't really be addressed to a significant level. So for surgery for the face turn, we can do an ipsilateral medial rectus recession like in this case and get good results. There are also some other options for the face turn. I'll not go into that. I will go to my topic, which is the overshoots. I'll begin by showing you this case. Here's a girl. In the primary gaze, she's orthophoric. And on adduction, her left eye overshoots, upshoots to almost disappear behind the eyelid. And in the left gaze, you can see that there is widening of the palpebral aperture and limited abduction there. Can you play this video, please? So you can see this is a video showing in abduction, her eye really overshoots. A 10-year-old girl. You can see that cosmetically, she's quite embarrassed about this. And if you look at the movement, you will see that on adduction, it's a abduction. Is
only one, and that's durability of the injection. Because patients are fed up today of going every month to the doctor, every month OCT, every month consultation, every month travel. Believe me, this adds to the cost of the injection. And newer anti-VEGF molecules are being developed primarily with single aim, that is to increase the duration of injections. So you see, there's a distinction between RCTs and real-world scenarios. RCTs may show excellent results because RCT I label as a red carpet treatment, because here the injections are given to the patient as free of cost. But in real-world scenario where patient has to pay from his own pocket, he realizes the pinch of that payment, and therefore compliance issue comes in. So as I said, there is a tug of war between all these biosimilars. And they're not only efficacious, all these biosimilars which are in the market, they're efficacious, but they're also cost-effective to the innovator molecule. So this is one example of, one of my patient who did respond. You can see this edema coming down here. But again, and one day this gentleman brought a chart, Dr. Saab, how many injections you will keep giving? And believe me, sometimes this may create an element of distrust also. So injection, not only they are physically, problematic for the patient, but also mentally also patient has a setback in this. And I remember one of the bank managers asking me, doctor, is there any permanent solution for this? Can I come less frequently? So at that time I said no, but today I can say yes. So I tabulated all the anti-VEGF which are available, bevacizumab, ranibizumab, and the lower line which is box, in red box. So this shows the approximate duration of action. So aflibercept is proposed 6 to 8 weeks of duration. Brodusumab is piped as, as 12 weeks. And the newest anti-VEGF which is in the market maybe in a month or so, 15 December is the deadline, this will enter India's market, faricimab, although it's got approved in 2022 in US, but I labeled 1 month, 1, 2, 3, 4 means 1 month, 2 month, 3 month and 4 month. This is the durability of the injection. And the last is the cost of the injection. So if you see the last two molecules, less the interval or more the duration of injection, the cost tends to come down because patient tends to spend less. So these are the various studies, based on which a lot of these molecules got approval in NAMD, Anchor, Marina, View 1, View 2, Hawk and Harrier, Tenaya and Lucerne. And on the right side, I have listed 1, 2, 3, 4 of all these anti-VEGF injections. So I'll not go through this Marina Anchor. This was the first pioneering study of ranibizumab. For the first time, they showed that graph can go up. Up means patient can gain vision now. Not only maintenance of vision, but gain of vision. And this is the View study of aflibercept, View 1 and View 2. Then Hawk and Harrier for brolucimab came up. Then Tenaya and Lucerne for faricimab. Similarly, for diabetic macular edema, remember always two parallel studies have to go on for FDA approval. We had RISE and RIDE for ranibizumab, then Vivid Vista, Kite and Kestel, then Yosemite and Rhine. Again, 1, 2, 3, 4 of all these anti-VEGF injections. So I'll again skip this RISE, RIDE study, Vista and Vivid, and Crestel for brolucimab and Kite. These are the latest talk of the town, Yosemite and Rhine study for faricimab, where they claim that Q16 can be obtained in at least 70-80% of patients. So thus to conclude that, we have gone far from 1 month to now 4 months of injection, and this is a good step, a welcome step and a positive step. So world is, believe me, moving very fast, and every day so many studies are going on. So 1, 2, 3 months is primarily duration of action. We have moved from 1 month from bevacizumab to ranibizumab to 2 months of aflibercept, 3 months of brodusumab, and now 4 months of faricimab. The ultimate barrier, believe me, is the cost and the durability. And COVID era told us that we used to inject, at lesser frequency, but it did help. So molecules which have longer duration of action, the compliance improves, and hence the cost comes down, and treatment effect also is better. So thank you very much for listening to this 1, 2, 3, 4.
Thank you, sir. Thank you for the wonderful presentation. And now we have Dr. Kaushik Murali, who is the president of Shankara Eye Hospital Group, which is spread all across India, and the kind of volume Shankara does. I'm proud to be an alumnus of Shankara Eye Hospital, and nobody better than Kaushik to speak on. This is a latest advances session. He'll be speaking on what is new in ICAM strategies, community outreach.
Thank you so much, Srini. I think I'm humbled to be a part of this session where I have 3 teachers who taught me ophthalmology along the years, Dr. JK, you yourself, and Dr. Sumita. Proud to be representing something that is not commonly spoken about when you talk of latest advances, where we are talking about community eye care. So thank you again for considering this important enough for this national symposium. We